So again, thank you for letting me be here and inviting me, Dan and Kelly, and thank you for all the attendees. Um, I'm honored to say that I get to do a lot of things in this space, both from the perspective of medicine, infection control, and working with ASHRAE, USGBC, um, as well as a couple other roles. And that is my dear dog, Luigi, who has passed away recently, sadly. I also want to thank my colleagues. I don't do this work alone. In there, you'll see some of the folks I work with. And in true ASHRAE style, I've disclosed a potential bias because I do have a patent on this algorithm that's up in the sky. Um, so I just want to be fully honest about that. So what do I hope we will all have learned by the end of this?
It looks like we lost her. Sorry about that, guys. We'll give us a second to get her back in.
Yes.
She's having some internet connectivity issues this morning. Our apologies.
I've
Oh, there she's back.
been fine all day. Okay, I need to share again.
Yep. Yep.
Um, okay, you see that,
Not yet, but
Kelly?
it was taking a minute for it to pop up, so it'll start sharing in a second. I noticed that your slides are a little bit on delay. Not terrible, but just a little bit delayed, so that's probably what this is.
I'm going to go past the learning objectives. Are you seeing the presentation outline?
Not not yet, Stephanie. It's still it's still loading up.
Still think no luck yet?
It has not. There it is. It just popped up. We're on learning objectives and now
Okay,
presentation
hopefully we'll be
outline.
good. Okay, so you're seeing the outline now?
Yes.
Yes, you're good to go.
So I just wanted to talk about these five areas. The first is how I, as a physician, came to realize how important the indoor environment is, and specifically indoor air quality. Secondly, what is some of the evidence that tells us we really need to consider health, both human health and the health of the microbiome indoors? Thirdly, how to manage holistically. Fourth, how do we determine the return on investment of healthy occupants? Because without a cost benefit analysis, it's really hard to convince your customers that this is necessary. So let's get going. Hopefully, we won't have any more problems. So actually, this is me when I was a medical student working in New Guinea. Um, this is before I got all the gray hair from connectivity to Zoom. But I was in my 20s. I went to Papua New Guinea for 4 months and was working in this hospital, the BWAC General Hospital. And I was really terrified that the patients were going to all get terrible infections. If they didn't already have one when they came in, and they were going to have terrible outcomes. You can see the men's tuberculosis ward. The concrete floor is dirty. The beds were close together. That's me in the operating room. We would wear flip-flops on our feet. Often we didn't have gloves. And yet, these patients did really well. They went home when we thought they would. They didn't have a lot of new infections. So when I returned to medical school, where the surfaces looked very pristine, private rooms, private bathrooms, I was horrified as I became
Oh no,
Oh, we lost her again.
that is not.
Guys, I'm back. Can you tell me when I'm online, Dan?
It's trying to bring you into the shared screen mode.
You're back. You're good.
All right, and Stephanie, you probably have about a 3 second lag before the slide that you've clicked on appears. 3 to 4 seconds.
So that means I should slow down my talking.
Yeah, or just click your clicker before you've ended your talking.
Okay. So when I came back to the Boston hospitals, I realized what a huge issue healthcare associated infections were and still are. So with that concern, and also the fact that I didn't know anything about buildings as a physician, I eventually went back to school, became an architect, well, got my master's in architecture, and really began to understand the power of this.
Kelly, I don't know if this is going to work.
Yeah, she's having a lot of internet issues. Um, let's see when she comes back on, if she can switch her
Yeah, if
internet
we can go
back
back
over.
to
Hmm.
go back over to see if her own internet is working now.
Yeah, the hotspot isn't working very well.
No, it just doesn't have the bandwidth and fully apologize for this technology at its best.
Okay, Dan, Kelly.
We hear you, Stephanie.
Okay, so
Would you like
I,
to see if your internet is working again and get off, see if that'll work over the hotspot? I don't think the hotspot has enough bandwidth.
I did that. I just did
Okay,
that and I'm back on.
perfect. Okay.
Ah, great.
Oh, good. Okay. We can see you, so that's good news. All right.
Something.
Something, yes. All right.
Okay, I am so sorry. So, okay. Am I here? Am I in?
Yes, you are, and that was a lot faster. So promising.
Okay. Again, I will apologize one last time. Um, so anyway, if we take a big step back and think about the trends in our buildings and in infectious diseases and overall in our health, it's really interesting and it's not totally obvious what's been going on. Clearly, our building technology materials have become increasingly sophisticated. We have public health strategies that we didn't have back in the BC time. So you'd think that with all of these advances in both hygiene and in building technology, we would have seen um, a parallel improvement in human health. And yet that has not necessarily been the case. We have, especially when you look at infectious diseases, as we move forward in time, certain viruses and bacterial and fungal organisms are actually becoming more virulent, and we're seeing increasing spillovers from animals into humans. We're seeing increase in antibiotic resistance. There are new fungal species that we now have to consider that are more virulent. While I don't want to paint an entirely doom and gloom picture, it is worth looking at how human health has evolved and how microbial pathogenicity has evolved, and ask ourselves, is there something we're doing with our indoor environment that's actually contributing to um, this not so great trend. So that's one of the questions I want us to look at. So let's talk about the extent of the association between our indoor environments and human and microbial health. Anyone who's heard me talk before has probably seen this video, but I think it's a very convincing evidence of who the occupants are indoors. So as I'm sitting here, somewhat stressed out by the internet connectivity problems, I'm talking and breathing. Droplets are coming out of my airways and all of your airways that contain particles, bacteria, viruses. Doesn't mean we're sick. That's totally normal. You can see as this engineer or architect is working away, she's leaving her skin particles on the desk, on the paper. As she exhales, you see particles coming out of her nose. Her GI system is quite illuminated because we have a lot of microbes and particles in our digestive system. And so the takeaways from this are threefold. One, we have very active communication between ourselves and the environment, which is primarily indoors. Number two, there's a lot of communication between surfaces and air. Particles that are settled on surfaces get resuspended, depending on turbulence, humidity. And thirdly, depending on how sealed your buildings are, depending on how sealed your buildings are, you will have more or less communication with the indoor environment. Kelly, are you still seeing this?
Yes, you're good.
Okay, good. So what are those particles? What are the organisms? Are they good? Are they bad? Are they indifferent? We now have a much clearer view of our relationship with the microbial world. And this relationship has evolved since we've started using genetic analysis techniques. Pretty much all of us are familiar with PCR ever since the pandemic. PCR stands for polymerase chain reaction. And it's a way of identifying the presence of either viruses, bacteria, fungal organisms by looking at their fingerprint, their genetic fingerprint. So it's much more granular, much more specific compared to tissue culture techniques. So that's all very interesting, but you might be saying, well, I'm not a microbiologist, so why does this really matter? It matters because it's totally revolutionized our understanding of how humans and microbes and the indoor environment interact. So one of the things we know is that each of us by cell number is about 70% bacteria, not by volume. By volume, we're each about 2 gallons of bacteria, but by cell number, we are primarily bacteria. That's not a bad thing. It's actually a very beneficial relationship most of the time. These microbes, they help us digest food, they help us think, they help determine whether we're going to be depressed or not depressed. They help us with our immune system. We get into trouble though when the microbial communities lose their diversity. So if you restrict the diversity, just like if you're a farmer and you only grow one crop all the time, you're going to deplete the soil, you're going to have less healthy crops. It's the same concept of diversity. When we restrict the diversity of the organisms we live with, we get into trouble with allergies, autoimmune disorders, inflammation, as well as cognitive problems. So when you think about that, when you think about the incredible importance of microbes in our health, then you combine the fact that we now know, based again on metagenomic analysis tools, that how a building is designed, in other words, what materials are used, the sizes of the spaces, and how the building is ventilated. Those characteristics are going to determine which microbes survive. So if you think about this holistically, it means that your indoor environment is really the most powerful force of natural selection. So it's another dimension of why we need to manage indoor environments for health. So with these tools, we've learned that the approach we used to have to surface hygiene, to air cleanliness, to taking antibiotics, is really based on an incorrect hypothesis that all microbes are bad. They're not. Most of them are good. Clearly, not all of them are good, or we wouldn't have had a pandemic. But we now know that instead of trying to kill everything, we need to create conditions that support diverse communities. And overzealous disinfection can actually be a problem. If you're in a burn unit, or if you have no immune system, or if you're in a bone marrow transplant unit, I would try to go for complete disinfection if possible. But most of the time, that's not realistic. It's not even beneficial. And in fact, one way to have a very healthy indoor microbiome is to get a dog. It's a little different with cats, but I won't go into that right now. Dogs and many animals actually have a very healthy microbiome. So if your bed looks like that, don't panic. This is what my home looks like. And I tend to be very healthy and don't get sick. So let's go back to humans and
Oh,
Dan.
hi, Victor. I'm in a meeting. Can I call you back in about 45 minutes?
Hopefully Victor will say yes.
I muted him.
So let's go back to, sort of a more where you're probably expecting to hear about in this presentation, which is how can we decrease the spread of disease indoors? And how can we really understand holistically the effect of the indoor environment on our health? So as a member of ASHRAE, I'm sure a lot of you or a number of you are familiar with ASHRAE 241, which is the new standard for decreasing airborne transmission of infectious disease. So ASHRAE 241 is really helpful if you think from the perspective of decreasing exposure to pathogens in the air. So the person on the left, the infected host, walks into your house, they've got a cold or COVID-19, they cough. Some of the viruses are going to go through the air and you are at risk for getting sick. However, the part that we're not considering in ASHRAE 241 and in other strategies where we only think about exposure is, what is the indoor environment doing to your immune system? Because yes, it's important to limit exposure, but it's also really important to support your own natural immunity. And we can actually do that in a quantifiable way. So how do we do that? So what I'm proposing is that we need to bring together building professionals and medical professionals, unite these two silos, and actually make human health, in my opinion anyway, the North Star to building management. So to accomplish that, we need to move from some of the metrics that we've been gathering in building. So we need to move from focusing so much on energy savings, although that's clearly very important, where we look at particles, gas concentrations, temperature, humidity, if you're in a hospital or an operating room, room air changes, pressurization, and add to that bucket of data metrics that directly reflect human health. So what does indoor air quality do to our immunity, to inflammation, our brain, our metabolism, as well as to the microbiome of the indoor environment? So how do we do that? Well, we can start by monitoring and measuring individual air constituents. We know that PM 2.5 is harmful. It can reach deep into your lungs. A study at MIT showed that if you're going to play chess and you want to be a world champion, don't vacuum at the same time, because even a small increase in particles decreases the efficacy of your moves. I mean, at the end of this presentation, there's a bibliography, so you can look at these reports. If you're an umpire, you don't want to have higher particulate matter in the stadium because you're not going to make as many correct calls. If you're going to take an exam, better to have decreased particles in the air. Particles get into our brain partly through our olfactory system, just from inhalation, partly through our circulation. But PM 2.5 can get through the blood-brain barrier and affect, multiple dimensions of our cognitive functioning. Not good. What about ozone? Ozone comes from, there's outdoor ozone, stratosphere ozone that gets down to the troposphere. Some of our electronics emit ozone. Ozone's really inflammatory to our airways. The EPA now monitors it outdoors, but we often forget about ozone indoors. So even low levels can turn a healthy looking airway, such as you see here on the left, into a very ragged looking airway with inflammatory cells, gaps in your epithelium, things that you don't want to have going on in your system. Believe it or not, low indoor humidity can be very problematic. It increases the thickness of the mucus in your airways. It impedes several steps in your immune system. It allows particles get deeper into your lungs. Low humidity, meaning humidity below 40%, is really problematic. Just looking at the time. In 2013, I was contributed to a study in a brand new hospital where a group of microbiologists were looking at the organisms in a brand new hospital, specifically in the patient rooms and nursing stations. So we were monitoring temperature, hand hygiene protocols, pressurization, all the things you see listed. And we correlated the patient room parameters with two things. One, with patient infections, and two, with the microbes that were present in the room. This study was done over a little more than a year. So we had a lot of data. We had about 8 million data points on the environment, about 400 patient outcomes. And this study was really pivotal for me, because what we found was that one of the most powerful drivers of healthcare associated infections was dry air. And I mean, I was not only startled, I frankly didn't believe it. You can see here in this graph that the red columns are infections. The blue line is the average relative humidity in the patient rooms. As the seasons, as the months went into the spring and summer, the relative humidity was higher. The infections were lower. So I thought, well, this isn't really about relative humidity. This is some other seasonal change. We reanalyzed the data and found out that in fact, relative humidity was an independent driver of infections. I was still not convinced. This is another aspect of that same study, where if you look at graph A, the blue line is showing the relative humidity. So again, it only varied between 30 and, up a little over 40%. But what we found was that the diversity of the microbes in the patient rooms, the diversity increased to a really healthy level when the relative humidity was higher. So this is good. Diversity is good. Lack of diversity is not so good. Furthermore, when the degree of pathogenicity, so the degree of badness of those microbes was analyzed, it was found that the drier environment, the drier air, actually carried more pathogens. And that's a really powerful finding. And as the humidity approached 40%, the degree of pathogen, the percentage of microbes that were bad decreased. So this was a healthier microbiome. I was still a disbeliever because I guess maybe that's my nature, but I thought it just didn't make sense to me that dry air was bad. So this is another study, actually over 4 years, where we looked at all kinds of infections, respiratory, gastrointestinal, urinary tract, cellulitis, and eyes, like conjunctivitis. And once again, at least with respiratory and GI infections, we found that there is this 40 to 60% indoor relative humidity, where the number of infections was the lowest. If you're looking at the green line, you'll see that urinary tract infections sort of had a mind of their own. That was more related to patient mobility and hygiene. But with many of the other infections, there was a sweet spot of 40 to 60% indoor relative humidity where the infection rate was the lowest. So after a while, I began to be known as like the relative humidity lady. And I got a little tired of that. So I said, I'm going to begin to focus more broadly on other indoor air constituents. So with that broader approach in mind, I embarked into the work that I'm now doing, which is looking at a broader number of indoor air constituents and understanding the effect on all of the different systems you see at the bottom, your lungs, your heart, your immunity, your brain, and general inflammation. So how do we do that? So a way to comprehensively monitor the indoor environment from this perspective of health is, one, measure the key constituents, analyze those from the perspective of the human body, obviously communicate that back to the customer, and then remediate. So how do you identify all of the indoor pollutants that affect our health? There are a lot of published guidelines to start with from the US. Malaysia happens to have really good standards. The UK, there is a very robust database. So understand what you need to measure and why you need to measure them. So measure them, but then the next step is to understand, where do these things go in our body? So for example, sulfur dioxide, which is quite soluble in water, is a powerful irritant, but because it's soluble, it tends to stay in our upper respiratory system, as opposed to, say, nitrogen dioxide from pollution, which is less soluble. And the consequence of that is that it stays in our respiratory system as NO2 and gets down and is able to penetrate more deeply in our lungs. And unfortunately, things that get really deep in our lungs then have the chance of getting into our blood system, where the damage can be quite distant from your lungs. It can go to your kidneys, it can go to your liver, etc. So understand what to measure, understand what those things do, and then not only what to measure and where they go in your body, but how do these things interact? So for example, how does ozone interact, say, with VOCs to create what are called reactive oxidation species? And how do those new molecules then affect your body? So if you're going to look holistically at the indoor environment and human health, you've got to look at it in totality. Again, I'm going through this kind of fast. And you can have this presentation and look at it, look at the references at your leisure. So understand the multi-pollutant effects on your body, then communicate this back to the customer so you can manage your buildings to support health. And then finally, this gets into we can now address the conundrum between how do you manage your building for energy efficiency and to support human health. And what I've been doing in my work is monitoring not only indoor conditions, but outdoor air, right at the building site. So by knowing what's going on outdoors, both particles, temperature, humidity, and gases, you can determine the best remediation steps for your indoor environment. So I'm going to give you a very brief overview of one case study in northern Minnesota. And this is in a senior living community. The report that I'm going to show you is from the summer of 2023 over about a 2-week period. So this graph is showing you the indoor air quality health score. So this isn't raw data. So in this graph, a low number here, anything under 50 is problematic. You want to have a good high health score number. And you see different lines because the blue is the overall health score. Green is showing you particles. Pink is gases, and the brown are thermal metrics. But you can see here around June 28th, just looking at the overall score, something happened to diminish the health score of the indoor environment. It drifted back up again, and then it came down again in the beginning of July. This decrease was due mostly to particles, and here we had a problem with gases, NO2 or ozone. It's not really clear from this graph. So that was the overall averages of indoor air health scores. But looking more specifically at different parts of the senior living community, you can see that there are certain areas that had more of a problem than other areas. So this dining room on the 3rd floor had a very clear decrease on that day in June. This office had some sort of ongoing problems. Looking outside, so the first thing I do is I say, okay, where are these things coming from? Are they coming from the outdoor environment? Are they coming from an indoor source? So looking outdoors, you can see, okay, June 28th, we clearly had a problem. If you remember back to a year and a half ago, we were having the wildfires up in Canada and the US were occurring. So this was most likely due to the wildfires. The other benefit of monitoring outdoors is you can say, okay, this is not a good time to have an outdoor barbecue or other outdoor activities with a vulnerable population. But then looking more deeply into what was going on, we looked at the individual data. So here we're now looking at PM 2.5. So a higher line is now bad. So it's kind of reverse of the health scores. So you can see that the outdoor PM 2.5 was probably the source of the low health score. How about carbon dioxide, which we often use as a marker of appropriate ventilation? The office, the turquoise bar is a reflection of the facility manager's office, and you can see, he needed to increase ventilation or at least maybe talk a little bit less in his office. So you're able to dive into the individual metrics and see what is driving a poor score. Carbon monoxide, same thing. The overall levels were okay for non-vulnerable populations. But in a senior living community, you clearly have a vulnerable population. So that would be, in my opinion, an opportunity to optimize your indoor air quality to support those folks. How about ozone? I was telling you before, ozone is very inflammatory to our lungs. What we found in this study was that there was an ozone source indoors that came from wheelchairs and scooters being charged up, and there must have been some arcing going on, and the charging station wasn't appropriately ventilated, so we had indoor ozone sources, which we never would have discovered without specifically measuring ozone. So what about the clinical symptoms that were associated with these poor health scores? When we looked at medical records and talked with the staff and the residents, we found there was increased fatigue, lack of focus. There are problems with throat irritation, irritability, eye irritation, headaches. I don't have it in this study, but we've also correlated with viral infections and health issues that required a transfer back to the hospital. So it was actually a really eye-opening study. Okay, but what about this problem? What about many of us are thinking about there's more focus on energy conservation compared to indoor air quality for health. So how do we balance this out? So again, when you monitor indoors and outdoors, you can take the most appropriate steps for remediation. You don't have to just have a set ventilation rate that's based on, you know, um, either one season or your presumption. You can actually determine when to decrease uh, ventilation or to manage outdoor air. Dan can tell you about um, appropriate ways to ventilate with outdoor air in a way that supports indoor air quality for health. So how do we determine the return on investment of healthy people? Many of you may have seen this. This graph is actually from the government, the GSA, where it shows that for your typical business, you're spending about 1% on your energy, total of 10% on rent or leasing, but you're spending about 90% of your business expenses on salaries. So if you broaden your perspective and don't only think about building costs, it's much easier to convince people of the need to support health. And again, when I was thinking about this sort of more broadly, thinking, okay, so for any given building vertical, what are the performance, what are the risk measures? How much are we going to focus on productivity versus energy? What is the building design? What does the building envelope look like so that you can appropriately humidify or take other strategies to support indoor air quality? And by doing this sort of a analysis, you can I think it's valuable to determine who do you go to first with this approach? Do you go to senior living communities? Do you go to hospitals? Do you go to commercial office buildings or schools? And what are the arguments for the economics of healthy occupants? Again, the next slide is real. Oh no, sorry, I guess I took it out. Nope, I didn't. Here's another case study in an acute care hospital. This was done by my colleagues at Site LLC, where they monitored the operating rooms in a somewhat small hospital in the Midwest. And they only used the operating rooms that had good environmental quality, good indoor air quality, based on the metrics that we've been talking about. So for example, they didn't use OR2, they only use OR4 and OR7 for some limited laparoscopic procedures, but primarily only the good indoor air quality operating rooms were used. They looked at the change in infections in those patients. What they found, it was really remarkable. They found an 87% reduction in surgical site infections. So that means you go in for a knee replacement or a hip replacement, and they found a huge reduction in surgical site infections. And this gives you the savings from the reduced infections, the revenue for the hospital. It didn't really even begin to get into a reduction in legal costs. That's a little bit harder to calculate because the transparency is much less. But the overall picture is that improved indoor air quality was associated with a tremendous reduction in surgical site infections. So then the next question is, well, what about the energy consumption in those operating rooms? They also found that by monitoring particles, monitoring humidity, temperature, VOCs, and other things that are harmful, they're actually able to have a safer environment when they turn down the room air change rates by 5. So with the reduction in OR air change rates, they saved quite a bit of money in energy. And you'll see there were different zones, different areas where the hospital drew energy from. So depending on where the energy came from at any given time, the savings varied. But it's an example of how improved indoor air quality was also associated with energy savings. If those of you on this call are convinced that managing the indoor environment for human health is important and you want to take this to your customers, I highly recommend that you figure out what the pain points are for a given type of building. So in a school, are you looking at academic performance, teacher absenteeism, student absenteeism? In a senior living community, how do you keep your residents and staff safe? What are the challenges that are associated with the indoor environment? Um, so how do you drive forward the argument? How do you create the not only the key performance indicators, but the health performance indicators that are going to help you convince your customer that this is something they want to implement? So anyway, that's kind of the end. Wow, I flew through that. So, you know, this this initiative is finally is really getting off the ground. ASHRAE has begun to um, embrace indoor air quality for health, not just for thermal comfort, not just for energy savings. So I'm really gratified to find that we're really moving from practices which talk about energy primarily, give a nod to humans in the form of comfort, and now moving to the next generation of indoor air quality management, where we are truly looking at health metrics. We're looking at the microbiome of the indoor environment. We're looking at the microbiome of people and how those are related to each other. So it's a really exciting time to be a building professional. It's a really exciting time to be an engineer, and I hope you realize the health consequences of what you're doing. These are just some glimpses of articles from ASHRAE. Max Sherman wrote IAQ Paradigms, the Next Generation. Max is looking at ways of quantifying health outcomes. Dr. McEwen is a ER doc from Scotland who's also working on this initiative. So in conclusion, I hope that we don't let that disagreement on the details of a health standard be an obstacle. People tend to say, well, show me the evidence that relative humidity 40 to 60% is a benefit. Show me the evidence that PM numbers should be whatever threshold you've determined. We can't argue about the details, or I hope we don't argue about the details to the degree that it becomes an obstacle. You know, bullet point 2, indoor air quality management can't entirely be based on ventilation rates. Ventilation rates are important. They're especially important from an energy viewpoint, but they don't really tell us what is going on indoors that's affecting human health. And thirdly, when we think about the transmission of infectious diseases, the presence of an airborne pathogen is part of the story, but it's not the whole story. The other half is what is the indoor air quality doing to our immune system and to other systems. And then what we've already been talking about are the benefits of good indoor air quality. So I like to point this out. I do a lot of skydiving, and one day I was skydiving and my altimeter was off by about, I don't know, 200, 250 feet. So when I came into the drop zone, unfortunately, my husband was there with a camera. I totally face planted. It was very embarrassing. I didn't get hurt, but it was embarrassing because I didn't have accurate metrics of my altitude. Versus on a really great day when I did, I was relaxed, I was having a great time, but I wasn't crashing into the ground. So if you don't measure something, it's really hard to manage it accurately. So that's my argument for monitoring the indoor environment from the perspective of health. Because why do we have buildings? Yes, we want to stay warm, we want to keep the rain and snow off of us. Yes, we want our buildings to be energy efficient and beautiful, but we primarily want shelters, from my perspective. Um, we want buildings to shelter us. So by creating visibility, we can have these three dimensions unified. Thank you so much, and thanks for your patience. Kelly and Dan, I'll send you this presentation. You can distribute it as you'd like.
Perfect.
Um, you can take a look at references and studies and
Well, we do have a couple questions in the
sure.
chat. All right, so the first one, I'm curious to know if you've given the same presentation to infection control professionals, and if yes, what was the outcome? Was there buy-in and increased want to partner with building and facility engineers on IAQ?
So infection
Yeah.
control. So yes, there has been good buy-in. There are a couple of obstacles, to be totally candid about hospitals. Hospitals are mandated to report their infection rates. So to ask a hospital to fully disclose their healthcare associated infection rate and then show an improvement is a challenging endeavor because they keep those data points under their hat. So yes, there's buy-in. However, I have found that hospitals are one of the hardest places to make progress. Matter of fact, that first study that I showed you from 2013, the microbiologist who sent me the patient data had forgot about HIPAA. He forgot about an IRB and ended up losing his job with that hospital. So hospitals are reluctant to disclose infection data. Senior living communities are a much easier place to move forward with this.
Another one, excellent presentation as always from Janice. One question, what does LUX stand for? LUX.
Lux is like the European metric for lighting.
Okay. Is there a community of practice anyone knows of this topic on this topic that we could join?
Wait, a community of what?
I'm thinking something along the lines of like an ASHRAE type of community for this type of practice, this topic that people can join that community.
Yes, and Dan and anyone. Oh, Kelly, you were at ASHRAE. So the Environmental Health Committee, it's really great. So the Environmental Health Committee at ASHRAE is now talking about bringing together building professionals and medical professionals. It was something I'd never heard before. So the Environmental Health Committee, and then there are two other groups that I'm a member of. One is called GP45C, which is performance metrics for occupied buildings. Um, and then there's a third guideline committee for indoor environmental quality and occupant health. So the short answer is yes, ASHRAE is really embracing this union of medicine and the indoor environment. And part of that is being led by the incoming president, Bill McQuaid.
Okay.
Stephanie, I have a question. Do you think it's coincidental that we have cold and flu season during our coolest, driest times of the year?
Coolest outdoors. Dan, no. Um, the flu season is really, at least in areas where you need heating, the flu season is the heating season. And low indoor relative humidity is a huge driver of that. So you bring in outdoor air with a given absolute humidity, you bring that into your building and you warm it up. So you increase sensible temperatures, but without adding water vapor, your relative humidity plummets. And I know Dan can talk much better about dew points and the psychrometric chart. I kind of stick with relative humidity, but it's not a coincidence, Dan.
And I think one of the challenges as well is the myth of a mixed air environment does it actually occur even during peak summer design conditions when diffusers are supplying air at terminal velocity? And I think that studies have shown that it's very difficult to evenly distribute contaminants and reduce contaminant concentrations, promote better environments. But when you consider during our cooler, low load periods of year, then it immediately compromises the whole mixed air environment presumption. And now we've got a room that really is subject to do all sorts of influences internally with regards to contaminants and pathogenic material that might be freely floating within a space.
That's a great point.
Sounds like you're working on building that presentation for November, Dan. We have a few more. So this one's a comment with the technical issue. So glad I stuck with it. It was a great presentation with new compelling arguments for measuring IAQ and sharing the info.
Oh, thank you. I am so sorry about those glitches.
You pulled it off, and
Oh my
yeah.
God, I need a vacation.
And then just curious about the resistance from hospitals. Is that the case? Is that the case across the board for hospitals in both US and Canada, or is it just US?
That's a fantastic question. So in my experience, Canada is an easier place to move forward with infection control, with really investigating that whole topic. I don't know if it's because they have a nationalized healthcare system or so that the financial pain affects a broader community. But in the US, and this is really interesting, pediatric hospitals are more likely to reveal their baseline infectious disease data. And I think that's because they're not constrained by penalties from Medicare. Because, for example, Children's Hospital of Boston doesn't have patients over age 65. So Medicare reimbursement's not as big an issue. So easier in Canada, and easier in the US and pediatric hospitals to get to implement these strategies. I'm not saying all hospitals are bad or obscure their data, but it is a challenge.
Yeah, very interesting. All right, that's the last of the questions in our chat. So
thanks, everyone.
yes, thank you everybody for attending. Thank you, Stephanie, for presenting.
You're welcome. I'll send this to you and feel free
Perfect.
to.
Thank you all. And Stephanie, always thank you for your time and consideration to be with us today.
Yes,
Thank you.
And look for an email from me with the recording and the presentation. We'll see you guys next month.
Thanks, everyone.
Bye.